Could we ask everyone to please take their seat? We're going to begin our program. Good morning, everyone. Morning. My name is Angelo Valente, and I'm the Executive Director of the Partnership for a Drug-Free New Jersey. I want to thank each of you for joining us here today for a conversation on knocking out opiate abuse here in New Jersey. I'd like to first invite Linda Harrison, the Director and CEO of the Newark Museum, to welcome us to this beautiful venue today. Thank you.
Thank you. I am very excited to have this summit here at the museum, at the Newark Museum, because I am a passionate believer that this is a subject, a topic, an issue that we as a museum need to be engaged in and involved in. Often we think that cultural institutions, we stand back and we allow the difficult issues to be handled and tackled by others, and we can't stand back anymore. We are a museum, and yes, we love to serve you wine and cheese and all those good things that surround art and culture, but as a modern museum of the 21st century, we must be engaged in issues like this, and I applaud you for the work that you are doing in this area. We do need to get ahead of it, and if there is one takeaway, it's that we must all be engaged in this fight. And as the Newark Museum, I am proud to say that we will be part of social justice and social issue conversations like this one, and we want to continue to have these types of conversations where solutions come out here at the Newark Museum. This is your museum, and I do hope that some of you who I've met, you have been here to the museum at events and summits like this. We want you to come in your in-between time and your off time. So as you leave today, when you conclude the hard work that you're doing with regard to this conversation, we will have a museum pass for each of the attendees today to invite your families to come and join you at the museum so that you can sit and have a relaxed repose and just take in the art and culture in our galleries. Thank you.
Thank you, Linda. Thank you. And I also want to thank all of you here today for attending Knockout Opiate Abuse Summit on the state and federal response to the opiate epidemic. And welcome all who are participating today by watching the live stream of today's event. I invite you and I invite all of you in the audience to participate in today's event and in conversation using the hashtag #KnockoutOpiateAbuse. In joint collaboration with the Horizon Blue Cross Blue Shield of New Jersey Philanthropic Arm, the Horizon Foundation for New Jersey, led by Jonathan Pearson, and the Partnership for a Drug-Free New Jersey, we are embarking today on a new 2-year Knockout Opiate Abuse initiative to address the opiate epidemic throughout community outreach, prescriber education, parent education, and a statewide awareness campaign. New Jersey is in the midst of an opiate epidemic. There's not a day that goes by without hearing or seeing a story in our neighborhoods or in the media of the impact of the misuse of prescription medication, heroin abuse, countless overdoses impacting all of our communities, and so many families dealing with the day-to-day challenges of the crisis and the disease of addiction. No family, no community is immune, and today we gather to learn how we can address the epidemic, how we can prevent more New Jerseyans from becoming addicted, how we can reduce stigma, how we can help those who are addicted, how we can support those in recovery, and how we could bring awareness to everyone in New Jersey about this crisis. The United States Surgeon General, Jerome Adams, called for a coordinated effort between community members, schools, parents, public health and education, law enforcement, healthcare, to address this ongoing epidemic. And today, we are representing exactly that formula. Today, we will hear from national and state experts, leaders and policymakers across the spectrum to identify the response at the federal level the state level, and look at how these policies and programs can be implemented at the local level at communities throughout the state. Over the past 2 years, the Partnership and Horizon have conducted nearly 24 town halls statewide to better understand the scope and impact of New Jersey's opiate epidemic. And with the help of so many collaborating partners in each one of our 21 counties, many of whom have joined us here today, the overwhelming majority of attendees of the 2017-18 Knockout Opiate Abuse Town Halls left these with knowledge and a sense of personal efficiencies on how to take actions for themselves and their families for the risks of addiction. Most significantly, the majority of participants also appeared to be highly engaged in a range of prevention actions, ranging from seeking additional information about opiate addiction to safely disposing of prescription opiates stored in their homes, and also asking questions about being prescribed opiates. This town hall series also involved the production of 2 special shows aired on NJTV, which helped to further spread awareness of the opiate epidemic in New Jersey. I am pleased to share the Partnership for a Drug-Free New Jersey and Horizon Blue Cross Blue Shield of New Jersey will kick off a new round of town halls with a fresh focus on customizing solutions to individual communities and leveraging local and national resources to combat the crisis. I am also pleased to announce the launch of a joint public awareness campaign between Horizon and the Partnership as we continue to work together to raise awareness through messaging that will appear across the state beginning April 1st on New Jersey Transit buses and trains and continuing across the next 2 years in locations and venues across the state. It's important to share these messages that will have an opportunity for people throughout New Jersey to participate in knockout opiate abuse initiatives and become part of the solution. Together, Horizon and the Partnership are launching also a 1-hour continuing medical education webinar that will be available to all prescribers across the state to strengthen safer prescribing of opiate through education. The accredited curriculum will be accessible through knockoutopiateabusedrugfreenj.org and fulfills the state 1-hour credit requirement on opiate crisis, including education on responsible opiate practices, alternatives to opiates for managing and treating pain, the risks and signs of opiate abuse, addiction and diversion. We know this effort will have an impact. Over the past 6 years, with our partners at the DEA New Jersey and HIDA, the Partnership has coordinated the Do No Harm Symposium series to educate and also provide information to prescribers. And through this series, we found that an average of 97% of attendees, of over 6,000 attendees, plan to make safer prescribing decisions based on the training they received. This new CME will give us an opportunity to reach more prescribers, more doctors, more dentists, and more nurse practitioners. Together, the Partnership and Horizon are continuing its efforts to educate parents in New Jersey through the 5th Grade Parent Alert. The 5th Grade Parent Alert is a resource guide for parents of New Jersey's 5th grade students to educate and raise awareness about the current opiate crisis, the signs and symptoms of opiate dependency and abuse, prevention and intervention strategies. The 5th Grade Parent Alert is designed to empower parents to become actively involved in prevention and responding to the opiate crisis as well. Educated and empowered parents and guardians are the first line of defense in preventing opiate misuse and illicit use by our children. There are no easy answers to solve the opiate crisis. It's necessary for all of us, parents, community leaders, students, and residents, to work together as a community to try to come up with ways to eradicate this epidemic and to change the public attitude towards addiction. And also, what we're doing today is the beginning of that process. What we're doing today will ultimately reduce and prevent opiate abuse throughout the state. The opiate crisis impacts every community in New Jersey. We are here today to find out how we can all be part of the solution. Thank you for joining the conversation. It's now my pleasure to introduce and welcome Alan Karp, the Executive Vice President of Healthcare Management and Transformation at Horizon Blue Cross Blue Shield of New Jersey, who will welcome us on behalf of Horizon.
Good morning, everyone, and welcome to this great venue and event today. We're really excited. I am really honored to be here today to represent Horizon Blue Cross and Blue Shield of New Jersey and welcome you to the summit. You've heard from Angelo about the problem that we have with opioid abuse in New Jersey and in the country, and we feel strongly that we want to contribute to try to come up with solutions, and that's why we're here today. So thank you, Angelo, for the introduction and your leadership in this area. I would also like to thank our speakers and our panelists today. I think we've assembled a tremendous knowledge base around this topic. And I want to thank all of you for your commitment and your attendance here today at this event. It's important that we hear from you and you get some of the answers that you're looking for. As the state's largest and most experienced insurer, Horizon Blue Cross and Blue Shield of New Jersey is dedicated to improving the lives of New Jersey residents. That is why we're proud to work with the Partnership of Drug Free New Jersey to bring you today's summit as an introduction to our Knockout Opioid Abuse Town Hall series that will take place in communities throughout the state and through 2020. This collaboration of our company-wide focus to use all of our resources, all the resources at our disposal to help end this public health crisis in the towns in which we live and work. Today's summit and the town hall series that will follow, and many other initiatives that are being funded through the Horizon Foundation for New Jersey, which is our philanthropic arm of our company. The Horizon Foundation has awarded grants since 2016 to help educate New Jersey residents about the seriousness of the opioid epidemic. The issue impacts every community in New Jersey. With more than 3,100 drug-related deaths in New Jersey in 2018 alone, it is clear that more needs to be done, and we need more people like you in the audience to become part of the solution. Through our collaboration with the partnership and other state and local not-for-profit agencies, we are committed to using this Knockout Opioid Abuse campaign to combat the opioid epidemic through community outreach, prescriber education, parent education, and through statewide awareness campaigns. Today we'll hear about some of the responses to the crisis at the federal and state level and their impact on New Jersey communities. We are off to a great start, and I think you'll hear more from the panelists today about some of the things that are being done to help to end this crisis. I want to thank everyone for their participation today. I would like to thank also Linda Harrison and the Newark Museum for hosting us today. As a proud member of the Newark Museum Board of Trustees, I'm glad we could use this venue to host this event. Together, we can make a difference in combating this epidemic that's destroying lives. And again, thank you for being here, and I hope you enjoy the program. Thank you.
Thank you, Alan, for your leadership. As together, today we continue the journey to save lives. As Alan mentioned, there were over 3,000 drug overdose deaths last year in the state of New Jersey, and over 14,000 naloxone deployments. The opiate epidemic is a statewide crisis, and we're very pleased that United States Senator from New Jersey, Cory Booker, is focusing on solutions in Washington. Unfortunately, he was unable to join us today because of a commitment in D.C. However, he did send a recorded message, which we're going to show at this point.
I'm Cory Booker, and I want to thank you all for gathering together today with such an important mission to deal with a true crisis in our country and in our state. I want to thank the Partnership for Drug-Free New Jersey. I want to thank the Horizon Foundation and all of you for driving forward this conference. We have this crisis in our country. We see it in New Jersey, 3,000 deaths alone last year to overdoses, heroin addiction, opioid addiction, painkiller addictions. These are scourges in our society, but we are not helpless. There are strategies that can work and are working. I've alone sponsored legislation based on some of the interventions I've learned about in our state, like St. Joseph's work. I've also been pushing our federal government to up their commitment to funding things that work. I will fight with everything I have in my office to support the efforts of those who are making a difference in our community. And we know this is not a law enforcement problem alone. We cannot arrest our way out of this problem. There must be informed care, interventions, early detections and prevention. I am committed to this cause. I am grateful for what you all are doing. I will be a partner with you in the success that we must have. Too much is at stake. Again, we are not helpless in this battle. So much of this must be about a collective commitment, working together, standing together and strong. I know what we are capable of, and I wish you all the best in this very important gathering. Thank you.
Senator Booker, who's been a great partner in raising awareness on this issue. In fact, in 2016, Senator Booker and Senator Menendez, along with the Partnership for a Drug-Free New Jersey, hosted the United States Surgeon General for a town hall meeting in Livingston. Senator Booker's staff has joined us here today as well, and we appreciate and acknowledge their commitment to this issue, as we know that he is lockstep with our efforts of the Partnership and Horizon to develop solutions to the crisis impacting so many of our New Jersey residents. As we continue to look at this epidemic from every angle, we are so fortunate today to have with us a keynote who has joined us from Washington, D.C. Rita Noonan is a sociologist and the branch chief in the Center for Disease Control and Prevention's Division of Unintentional Injury Prevention. Dr. Noonan and her staff oversee the $300 million Overdose Prevention in States initiative, a combination of prevention, intervention, and public health surveillance programs to reduce opiate-related overdoses across the United States and U.S. territories. Dr. Noonan works closely with several groups, including HIDER, managing the public health component of the Office of National Drug Control Policy's Opiate Response Strategy that links public health and public safety across 24 states. She has been the recipient of several prestigious awards, including a Fulbright Scholarship and the MacArthur Fellowship. She received her PhD from Indiana University, and now let's give a New Jersey welcome to Dr. Noonan.
Thank you so much. Thank you. Thank you so much. Thank you for the warm welcome. Thank you. And to the venue, this is just a beautiful, beautiful space, and I'm so glad that we have folks from all walks of life in here. I'll try to tailor my remarks to the kinds of things that I hope all of you can leave here and have a better idea of what you can do when you leave. So thank you to all the organizers, and thank you for being here. I'm actually here today because Dr. Redfield, who runs the Centers for Disease Control and Prevention, could not be here. He has other engagements, and I just wanted you to know that he sends his regards. We thought really hard about who to send here in his stead. Those are very large shoes to fill. And we thought really carefully. We knew we needed somebody who could talk about the funding that was just put out on the street. We have lots of state-based programs. We also wanted to be able to have somebody in front of you who can speak intelligently about our science and all of our research, and also somebody who can speak about our partnerships. So unfortunately, that person wasn't available, so you got me. Not true. I can talk about all those things, and I will. So let's get started. I'm going to turn my head occasionally just to see my slides. Unless you've been living under a rock, I think all of you are here because you understand the devastating nature of this epidemic, and it does meet the definition of a public health epidemic. that term we reserve for special occasions when there's a sharp increase or spike in the health outcome of interest. This epidemic has now, you've seen the progression here on the map where these are county level overdose rates. Red signifies a hot spot or an increased problem. And you can just see how it has just slowly and relentlessly taken over more and more parts of our country with those darker reddish colors. We have already surpassed the number of deaths due to HIV at the peak of that epidemic. If you want to just put it into perspective and do a little social math, you can think about, the peak of, things that are everyday killers that we know are everyday killers, like motor vehicle crashes. We've surpassed the level or the number of deaths due to that problem as well at the peak of that problem. So we are literally talking about the public health epidemic of our lifetime. And some of us were around for HIV, and this has already surpassed that. So I just want to put that in perspective for you. We often talk about waves of the epidemic. We do say there is an epidemic, but technically, to sort of situate this with some of the science and the work the CDC does really well. CDC, by the way, you hear our numbers all the time, right? We're kind of known for that. We do a lot of what's called public health surveillance, as opposed to, say, law enforcement surveillance. We're not putting, wiretaps on anybody, but we are surveilling major trends, health trends in the country. And we typically do that through administrative databases. It could be vital records, but we are sort of the data people. So when we started looking at this problem a number of years ago, we noticed that there was some anomaly, and it looked like there were a number of deaths that were increasing, and it was falling into what we called poisoning at that time. And we did some early investigations and realized that, these are prescription drug overdoses. How do we know this? We went to states like West Virginia, we went to North Carolina, and we did what we call epi-AIDS, these rapid investigations that public health entities like CDC, I think, do very well. So field investigations. So you'll see what we call the first wave was actually due to prescribing, and I'm going to say over-prescribing. Prescribing is still very, very high, but prescriptions went up, the number of prescriptions went up threefold, fourfold over a period of time. But what Americans report in terms of their pain has not tripled or quadrupled, so you can think about it that way. We also did a number of reports that showed the kind of prescribing across the United States was highly variable. So you had prescribing in, say, Alabama that was 3 times as high as Hawaii. And living in the South, sometimes they'll say, well, it might be a little painful to live in Alabama. I can say that up here. I'm just teasing. I'm from the Northeast, you can tell. I'm slowing myself down so I don't talk too fast. But we really quickly realized that prescribing is all over the map. And just the sheer number of prescriptions was well over 250 million, which is the last year where we released a big report. We called it a vital signs. So clearly, I think you know this, prescribing was really the first wave. And what that wave did was it essentially primed a population to have a taste for opioids. So what happened in the second wave, and you can see these markers there that say the second wave, that's really the rise in heroin deaths. And you can say, well, why would that happen? Well, drug traffickers are in a very lucrative business. There was clearly a population that could be exploited, and was. If you ever want to read a nice, I think, good summary of this, you can read Sam Quinones' his book Dreamland. Who's read Dreamland? Okay. I recommend reading it, and it's out in paperback, and he's also just a wonderful speaker. If he hasn't been to New Jersey, I would say maybe invite him. But he catalogs how a subgroup of traffickers in Mexico identified all these little markets in the Midwest, and they just created a marketplace and a business model that was almost like serving pizzas. Just quick turnover, very, almost like the corner of your street, there could be a delivery there. So it just kind of changed the model of how people sought drugs. And I'll leave law enforcement experts to say more about it, but basically the price of heroin went down, the purity went up, or the potency went up. So we had a big heroin problem. You can see that started changing right around 2010. And then the third wave, what we're calling the third wave now, is illicitly manufactured fentanyl or any of those synthetically manufactured opioids. It's not from a poppy plant. This is typically a white powdery kind of substance that is made in labs overseas, mainly in China, trafficked through the organizations that are typically trafficking these drugs. So you have I don't know where you all come from, but just sort of understanding the context, and I realize a lot of people don't know that the major fentanyl problem is east of the Mississippi, primarily because of the kind of fentanyl, the powder that it is much more easily mixed into white powder heroin, and now it's just sold on its own. It's pressed into pills. It's really just run. It's run amok, and it's very, very hard to contain that kind of problem. I'll let law enforcement speak more about that, but you can see very quickly how this has evolved, right? So we started with prescriptions. The interventions that you would go after for prescription drug overdoses is somewhat different than you would than you would apply for, say, a heroin or illicitly manufactured fentanyl problem. So it's a very tricky problem we're trying to wrap our hands around. And then just when you think you're getting some traction, here we go with psychostimulants. Cocaine is presenting all kinds of new problems. How do we know this? Because our public health surveillance programs are indicating that an increasing number of stimulant deaths are due to what is likely fentanyl mixed into the cocaine supply. Meth is back. Again, we'll let DEA and law enforcement people say more about that. But we may be looking at what we're going to call a fourth wave, which is related to the psychostimulants. And that is, it's a challenge. So what I'm painting for you here is some of the challenges, some of the background, but I will make sure that by the end we leave with some ideas of how, I think Senator Booker said it very nicely. We are not helpless. There are things that we can do, and I will make sure I land on those before we close out here today. And just to put it in perspective, we talk a lot about deaths, and I think we should. The number of deaths is staggering, over 72,000 overdose deaths, and about 2/3 of those are due to opioids. So we're talking about an unprecedented number of deaths due to drugs, drug overdoses, but it's really the tip of the iceberg, right? When you think about, you can see, I won't read all these, you can see what's up here, but the tip of the iceberg, that's the number of deaths, but you could think about the devastation within families and communities when you have people who are either addicted or dependent, may not be able to keep a job. There are places where children are watching their parents overdose. Some children are pulled out of families for that reason. And you can just see the whole cascade and the ripple effects across all of our families and communities, and it is quite devastating, as you know. Okay, so again, just putting it in perspective, this is the first time in 100 years that we've had 2 and what looks like 3 years of decreasing life expectancy in the United States. And the last time this happened, it was the flu of 1918. That's perspective, right? Lots of these other conditions have improved. We can say, well, that's why people are living longer. We've done better with treating, say, cancers or heart disease or stroke. But you can see that drugs are significantly affecting our lifespan in the United States. So, well, what do we do about this? And why is CDC even standing here in front of you? CDC is I will go out on a limb, we are the premier public health institution in the United States and probably the world. We are charged with keeping the public safe, healthy. This is just one of the health conditions that we are now focusing on, and I would say in a very, very significant way and increasingly in a coordinated way. So I just wanted to show you, CDC puts money out into state health departments, increasingly with some cities and communities, and CDC is actually the entity that will report those numbers out. So if we don't save lives and that death count doesn't go down, I think no one's going to think CDC did their job, right? So we are focusing on a number of areas here, and I'll highlight some of them for you. I mentioned surveillance and research. We're known for that, and you'll hear CDC cited very often in the news, for example. But we also build state and local capacity, and we work through those kinds of partners, typically state health departments, but increasingly you will see that we are funding some cities in this round of funding that's on the street right now. We're going to fund some major counties and cities and territories. We also have a focus on health systems, and I wanted to make sure I've covered some of this because I know Blue Cross Blue Shield and your philanthropic arm is here as well, and there are really a number of health system-related interventions that I think are very powerful and very promising. And we're trying to create more of those tools that providers can use to increase capacity for care and coordinated care. We have some really nice products, I think. Partnering with public safety, I'll say a little bit about that. And it was already introduced that I work with the high-intensity drug trafficking areas, and we're really trying to deepen our connection with those folks. And then there's a little bit we're doing with consumers. So I'll touch on these things really briefly just to give you a sense of what we're doing, and hopefully I won't exceed my time. Once you stand up here, you think, oh, 30 minutes is a long time. You just be so surprised. You just start talking, and next thing you know, somebody's giving you the hook. So just to give you a view of where we fund, we basically fund every state in the United States. There's a variety of different funding mechanisms that we use to either do surveillance or prevention activities. We actually have some territories in the mix now, and we will have cities next time. So that gives you a little bit of a sense where we are, and that's everywhere. What are we doing? Well, here's one of the things we're doing, and I don't want to get too in the weeds. I'm not sure that this audience cares that much about all the ins and outs of how we collect better data, but just to help you understand why we invest so much money in better data collection. For years, we were looking at this problem the analogy would be if you're driving, we were looking in the rearview mirror. We were looking at death numbers and data and information that was years old. And you just saw those waves of the epidemic where you could see how quickly things change. How can you possibly get out in front of something if you don't have good information and timely information? So what we're trying to do is get better information about fatal and non-fatal overdoses. We fund states to do that. New Jersey and all the states are eligible to apply for this funding, and there will be even more funding next year. So I'm really looking forward to that. And some of the information that we get is very, very quick. We're not necessarily going to get great estimates, but we'll know if there's a blip or a hot spot. And then we want to very quickly work with folks like you to say, there's a hot spot over in your community or your county. And then, of course, you have to know what to do when you find out about a hot spot, and I think we're still working on that as well. Prescription drug monitoring programs, of course, are the ways that states have cataloged and understood what kinds of patterns there are in prescription use. It can pick up, depending on how they're used, it can pick up, say, what used to be called, or sometimes still is called, doctor shopping. So you might have a patient, these are very high-risk patients, if they're going to multiple providers. Your provider may not even know that you just went to, or somebody went to see some other doctors. And a lot of it can be very innocent and inadvertent, that you might not understand that this is risky when you have multiple drugs from different kinds of providers or different pharmacies. Law enforcement has used these systems very well to understand where you might have a rogue prescriber or somebody who is, doing some kind of fraud. So they're making money by dispensing drugs or writing prescriptions to people who actually shouldn't have them. So there's a number of ways these systems can be used very well across the states. This is one of my favorite things to talk about when I'm with an audience like this, because you all work for different organizations. I'm assuming some of you work in, health or healthcare systems, maybe harm reduction, behavioral health, counseling. There's all kinds of ways that we can say, let's do something. We all can do something. But where do I go? How do I get this information? How do we even know, like, that intervention is better than this other intervention? So we just kind of did a scan of the literature. We tried to just weigh the evidence and say these interventions look the most promising right now. And there's 10 of them in this little booklet. It's available online. And we tried to just cover the waterfront a little bit. So if you are working in, say, a community organization and you have the ability to refer people and link them to care, or let's say you work in an emergency department, we still have many healthcare systems that somebody will walk in the emergency department or be brought in by emergency services. They'll have an overdose and they'll walk right back out. There's no care plan, there's no treatment, there's no protocol. So I think there's a lot of room for improving how we do this kind of work in our community. So this will be one of your booklets if you want to make a note of it. It's all online, and I think it would give you some concrete ideas about things that we think have the strongest evidence at this moment. And again, evidence changes, but evidence matters quite a bit, and I'm glad that that Senator Booker also made that remark. Okay, so this is basically a nod toward the local context, which is where most of you are working and most of you are interested. We have a new funding announcement on the street right now, and it's $315 million. And we have asked all the states and eligible recipients to pass at least 20% of that to localities. So if you are in New Jersey and your state is going to get millions of dollars, I think it would be wise to talk to the people in the state health department, talk to the applicants, and say, hey, we have a really good thing going. here in Newark or in some other part of the state, that we have an idea of how we can help all of us move that needle by using evidence and using the best existing evidence. Sometimes states have a hard time spending money. I know that sounds crazy, but there's a lot of rules about spending money and contracts. And I have found that anybody who gets millions of dollars at a time is often really grateful to have a community partner or any kind of partner, health system partner, say, we really want to help you advance this work, and here's how we can help you. So you might want to be thinking about that if you didn't read that funding announcement. I'm sure that's what everybody does at night, right? What's that CDC funding announcement looking like these days? But I do think it's very promising and could offer opportunities for you. Linkage to care, this is one of the things that we will be encouraging through our funding, but also through any kinds of partnerships. And I would encourage all of you to be thinking about, what did we learn from the HIV crisis and epidemic? Well, one thing we learned was that a lot of treatment facilities had to be ramped up very quickly. They had to expand their capacity, and that getting people on the antiretrovirals was a really critical way to suppress the viral load and thereby stop transmission. So the analogy for us is, medication-assisted treatment works. It works not 100%, but it works better than the alternatives if you look at the evidence. Not everybody will want to be on a medication to treat this, what we call opioid use disorder, but lots of people will. And we've used medicines very effectively in the past to treat different kinds of health problems. So you were mentioning, or I think early speakers mentioned stigma. There's still stigma around not only having an opioid use disorder, but also about how do you treat that disorder. And there are folks who say, well, why would I treat one addiction with another medicine? So there's a very strong impulse to do abstinence-only programs, in part modeled from the alcohol movement. But if you look at the evidence, and I know every patient is different, every provider wants to treat patients individually, and they should, but the weight of the evidence does suggest that medications for opioid use disorder are much more effective than not using medications. So I would just sort of signal that to you, and I don't know if that's news to you or not, but I think that's actually really important, and thinking about those opportunities to link to care, whether it's from a community organization. We have fire stations, we have police stations that are linking to care, right? So safe stations, some of these grew out of New Hampshire and Rhode Island, and you might be doing them here as well. I think there's just a lot of promising avenues where you just use the model that no door is the wrong door. So in your communities, if you're not doing this already, I would take a page out of the HIV book and say, how, when, and where do we find people who most need our help? Understanding that they won't always be ready when you think they should be ready. So if somebody has had an overdose and they're in a medical facility or an emergency department, the patient is feeling pretty lousy if they've been reversed with naloxone. That reversal agent, Narcan, it's called sometimes naloxone. They're feeling terrible, dope sick. When you are addicted to heroin or fentanyl or a prescription opioid, you feel very sick when you're coming off of that, which is why that merry-go-round of having to keep using, in some cases, keep injecting. A lot of people are going to leave that emergency department and feel like, I just need to go find something so I'm not sick right now. And it might not be the most opportune moment, but it might be. So there's lots of programs now for linkages to care where they follow up with somebody maybe at another service provider, or maybe they follow up in their community. And I know law enforcement's doing some of this in combination with, say, social workers. Public health is trying to do it. So that post-overdose follow-up and outreach, I think, is really critically important. And just understanding not everybody is ready for treatment when we think they should be. So I just wanted to highlight that. And again, you might know all these things. I'm trying to just highlight the biggest lessons learned that I've had over the last several years. So basically, I mentioned this already. I still think it's super important to think about safe prescribing. There, I think, has been some public conversation about the CDC guideline, which we released in 2016. And that guideline just tried to give better advice about, here's what we know about prescribing opioids. First of all, we know there's a lot of them in circulation, in many cases unnecessarily so. But if they are deemed to be a benefit, there's safer ways to prescribe. So we wrote a guideline. Some people like it. I think most people like it. Some were very worried about what the implications might be, especially in how policymakers might pick up a guideline and put it into practice. But for healthcare systems, and we work very effectively with them, I think they've been really careful about understanding how can this improve my patient safety, basically, and how can it improve my health outcomes, and in some cases improve the bottom line for some health organizations. This was the guideline. Again, if you're having trouble sleeping at night, feel free to go look up this guideline. But I think it really was a watershed moment for us to at least put some stake in the ground and say, we're not telling you what to do. Every relationship is different with your provider, but we're trying to say is, here's what we know from the evidence about some of the risks. And for example, we know that if you stratify or analyze your population of people who take opioids, and you look at the ones who are at the greatest risk of being addicted or dependent, and that is people who misuse the most, right? That would be the category over here on the right, number of times you misuse. So you're talking about high-risk people. That population actually reports that they are getting the majority of their opioids from their physician. Now, the really tall kind of teal-colored bars, that's getting it from a friend or family, and we know that some of that happens. And some of it is just plain diversion, or people find it in a medicine cabinet. But your really, really high-risk group that's misusing the most, we still have a significant problem with people getting it from their own physician, right? So we still think very important to be thinking about safe prescribing. I opened all this by saying, the runaway train of fentanyl and all those analogs, that is true. But at the same time, prescription opioids do constitute a pathway toward opioid use, and there's still very, very high levels of prescribing. Again, if you just look back historically or compare us to other countries, we're about 3 times higher than Europe. So we consume the vast majority of the world's opioids, of prescription opioids. So we think it's still important to follow the guideline. If you work in a healthcare system or are a provider yourself, I think that there's still a lot of value in understanding how, when, whether to prescribe opioids. That should be a very momentous decision. There's really good research that the first prescription sort of sets the tone for whether or not somebody will be taking opioids some number of months later. So it should be considered very carefully. And I think I won't go into ins and outs of the guideline, but the guideline sort of chunks this out into, should you use them at all? If you do, proceed very carefully, start low, go slow. And then there's all these risk reduction things and kind of the third category, that if you have a very high-risk patient, you might want to co-prescribe naloxone, for example, or you might want to think about tapering. We always tell physicians and health systems, you don't fire your patients. This is actually bad for the patient, puts the patient at risk. What we want to say is, have conversations about tapering, or have conversations about just being safer in how opioids are being used. So I won't belabor that. Just real quick, anybody in the healthcare system space or anybody in the provider space, we have really a nice number of materials that we've created so this guideline doesn't sit on a shelf. We have a lot of these available online. We have physician education, all the CMEs. We've broken them out by topics. You can look all these up. They're all cataloged. We also have things for insurers, which I think would be really great to dig into, perhaps with a different audience. But you can contact me or contact CDC if any of these look like it might be in your wheelhouse. And one that I will show you shortly is just aimed at the general public. This is just my nerdy little, anytime you work in research, look, there was a study on this. The research did suggest that the release of the CDC guideline did help advance some of what we think of the improvements in prescribing. So basically the guideline, we think and hope, is doing what it's supposed to be doing. So we're moving now, that wheel I showed you of all the CDC activities. I'm going to shift now to working with law enforcement, which I think it's been a really gratifying and wonderful experience. And I know Senator Booker said we can't arrest our way out of it, and several people say that. But similarly, we're not going to treat our way out of this either. And I think prevention is very important, but at the same time, if we have, want to use an analogy, we have a patient in front of us, the country, that is, bleeding to death. So I think we have just a number of things we have to do concurrently, right? We do need to make some arrests, of course. We know we need to reduce supply, but we also need to work on the demand side. And there's so many things that we're learning from each other. And this particular initiative, I think, is very gratifying because we're all trying to improve what we know and how we do it. And that only happened by getting in the trenches with people that we didn't work with before. you're all from communities and you're probably doing that already, but I think I can't overstate how important it is to just talk to people and figure out, what do you know that I don't know? How can we do this better? How can we be open to what we don't know? So there's a lot of rigidity, I think, in our disciplines. We call them all of our silos. But this has been one where we really were forced to do some things differently, and I think it's really wonderful. So we have a public health advisor and a drug intelligence officer in every one of these 24 states, and we have things that we work on together for data sharing, for different kinds of projects to generate knowledge. But I think it's a really nice model. So if anybody's interested or wants to learn more, New Jersey is part of this. I know we have other colleagues in the room who could probably talk about this, but I'm happy to tell you more. And I'm hoping this will work. This is a video. This is going to my last little spoke on that wheel of the CDC activities. This is, and I'll give them a minute upstairs. I know everybody's worried. If it doesn't work, it doesn't work. Basically, there's a campaign that we have for the public, and we created this campaign with a lot of formative research. We feel good about the messaging and the way that it's delivered. It's basically a testimonial style. It's a testimonial
who is
style
struggling
campaign.
with opioids.
I got my wisdom teeth taken out. I must have got.
There's the sound. Am I supposed to click something? Well, okay, if it doesn't work, you can look it up. It's online. And states can use it, communities can use it. Basically what it does is it takes real people who have had, have been affected, people with lived experience, who are speaking about their experience and basically the risk of this class of drug. So when you're going to your doctor, for example, a dentist, there's millions of wisdom teeth extractions every year for teenagers. If you're a parent, you want to really think hard before you or your child or anybody you know takes that first opioid. Doesn't mean you never should, but you want to be informed about it, right? So this is a campaign that
I got my wisdom
walks
teeth taken out. I must have gotten a 30-day script. I took them all in 3 days.
My son was 20 years old when he was prescribed opioids.
Nothing mattered more than getting my fix.
My son Steve did not want to die, but his prescription opioids killed him.
And thank you to the people upstairs who made that happen. Thank you. It never works for me when I'm up here on the stage. So basically, this testimonial style we've used for other public health campaigns, like the TIPS campaign from former smokers. So you can use it. We have some branding on it, but we let locals, states, whoever wants to use this. I know it sounds like you have your own thing going here, but we feel good about this one. It's getting very good reviews. So anything that we make at the federal level, we want people to pick it up and use it. So I believe I'm out of time. Good. My timekeeper didn't give me the hook yet, but I just want to thank you so much for being here, and I hope I touched on enough things that I think you can leave here and work on, because truly, I'm not saying this just because I'm supposed to, but everybody can do something, whether it's in your family, it could be your community, it could be how you talk to neighbors, it could be how you talk to people in schools or your dentist, or whatever it is that you think you can do. There's so much that still can be done with interventions, but also reducing stigma and working across all of our silos and just doing more and doing it better. And it's important that we do, because the death count is just continuing to mount. So I'm very honored to be here with all of you, and I look forward to continuing to work together, and just thank you so much.
Thank you, Dr. Noonan, for your insightful presentation. Dr. Noonan will now join our panel discussion. And before I introduce the rest of the panel, I just wanted to acknowledge and thank the staff of both the Horizon Foundation for New Jersey and the Partnership for a Drug-Free New Jersey for all their work in coordinating this event. It's been several months of planning, and we have had great collaboration between the two organizations. So let's give them all a round of applause. I also want to acknowledge one of the board members from the Partnership for a Drug-Free New Jersey who's here, John Azzarello, who's representing our Board of Trustees. John's in the back of the room. Thank you, John, for coming. And now we're going to bring up our panel. First, we have Suzanne Kunis, Director of Behavioral Health Solutions for Horizon Blue Cross Blue Shield of New Jersey. We next have Susan Gibson. Susan is the brand new special agent in charge of the Drug Enforcement Administration New Jersey Division. We want to welcome Susan, and Susan has been a great ally and a DEA of the partnerships for decades, so we appreciate their support. Next, Erica Liu. Erica is the Chief of Opiate Abuse Prevention and Enforcement for the United States Attorney's Office, District, New Jersey. Thank you so much, Erica, for joining us. Our next panelist, Sharon Joyce. Sharon is the Director of New Jersey CARES, the Office of the Coordination of Addiction Responses and Enforcement Strategies with the Department of Law and Public Safety in the state of New Jersey. Thank you, Sharon. Our next panelist, Ann Hazlett. She's a Senior Advisor for Rural Affairs for the White House Office of National Drug Control Policy. And finally, we have Dr. Anthony Ferrari. Dr. Ferrari serves as the Regional Director for Region 2 of the United States Department of Health and Human Services. So we're going to begin with Suzanne. Suzanne, what role does Horizon Blue Cross Blue Shield of New Jersey, as the state's largest health insurer, play in addressing the opioid epidemic?
Well, first of all, thrilled to be here today. Dr. Noonan, your presentation was delightful because it's so much of what we're focusing on as we try to create programs and services for the people that we are responsible to care for. Horizon has 3.6 million plus members here in the state of New Jersey, and that's over 50% of the market, which is pretty significant, as you can imagine. And the fact that we're here today, it's really to show our commitment to continuing to move forward with trying to find solutions in this space. We have worked very hard, at least I've been with Horizon for the last 2 years, and one of the early things that we did was really look at what are the obstacles in New Jersey, what are the challenges that we're facing in New Jersey as it relates to substance use disorder treatment or mental health, and in this case in particular opioid use disorders. And I think Dr. Noonan put so much of this out there today in terms of really the stigma that's associated with treatment. But every person in this room, I could almost ask for a show of hands, know someone, family, friend, colleague, neighbor, who is struggling with this issue. It's an issue for every person, every town, every community. And so we are trying to, as part of Horizon, take on the challenge of stigma and really try to get people to view mental health and substance use issues as their health. It's just like going to a doctor. If you go to a doctor for diabetes, cardiac conditions, we need to start treating this as a chronic illness. And it's one of the things that is a challenge. I know insurance companies have gotten a bad rap in the past about we just want to make sure we get our costs lowered and we don't want to pay for treatment, et cetera. But I have to tell you, being here for these last 2 years, we are doing everything we can to throw things against the wall to try to change the curve here, because it's such a horrible disease and there are no solutions that are actually working today. Lots of great work is going on out there. I think MAT was a terrific example. That is the evidence-based treatment. But we don't, from a state of New Jersey perspective, we don't have enough MAT services here. So what's Horizon doing? So we're working with our provider network to encourage the development of these programs and services, but we wanted to go further than that. We literally went out to other states, and I personally went to clinics in Kentucky and Illinois to look at how some of these community-based organizations are actually taking actions that are making a difference. When people talk about medication-assisted treatment, you think of getting a prescription. It is so much more than that. You can't, we talk about the X waiver and how many providers, physicians actually have the X waiver. Yes, you need to have that today, which is interesting because you don't need anything special to prescribe opioids, but you sure need something special to treat people with opioid issues. But beyond that, there is the whole rest of the program where you have to include all the supportive therapies that are necessary to help somebody to really recover. Just getting a medication is not the answer. You need to have interventions of a psychiatrist, intensive outpatient services, and ongoing community services. So the one thing that I really think is important that Horizon is trying to stress is there's a lot of service available, but we think the system, or at least I will personally speak to this, the system's kind of broken. What we're trying is just not cutting it. So now is the time where we have to invest in making significant change. And that significant change, in my estimation, is really focusing our dollars as a country on community-based services. SAMHSA implemented a model of care a couple of years ago. There are grants in 8 states, and New Jersey, thank God, is one of those that went forward with actually applying and being granted. It's for the Certified Community Behavioral Health Centers, CCBHCs. It's a model of care that is full service. They will do everything from ambulatory withdrawal management to medication-assisted treatment inductions to treatments to crisis services, hands-on case management. That model I love because it really is something. We want to keep people in the community because guess what? Someday, hopefully, you're going to go home. And unfortunately, we've seen so many people that have gone off to other lands, Florida, for example. I know we hear a lot about treatment in Florida. But I can tell you, we just looked at 40 individuals who were high utilizers and sitting in Florida who went there from New Jersey. And when you look at what's happened to them, it's a crime. We're seeing people who are down there whose families were desperate. Clearly, as a parent, if my child was suffering and I tried everything I could locally and nothing worked, I would do anything to get my child taken care of. But what's happened is these kids go down there, and then the parents actually get to the point where they kind of disengage. They've got the insurance coverage. We're seeing the profile of those kids being 20 to 26 years old. And what's happening with them is they go through treatment, and then they wind up just going through this vicious cycle. Treatment, I go to outpatient programs, I live in sober housing, I'm having a relapse, I'm going back into overdosing. It's horrifying, and we need to do something, and what we're trying to do something as the insurer here is not only address those kids or people that are already down there that we need to do something different with, but try to have what we're calling our Project Home initiative, which is make sure in the state of New Jersey we have solutions that people can use right here in their backyard. And treatment for opioid use disorders is not a sprint, it's a marathon. This is long-term community-based supports that are needed. We're talking everything from, every level of care is out there, and we just need to use it smartly. And making certain that people know where those services are, making sure medication-assisted treatment is available. The providers who may have historically been abstinence-based providers know that we are expecting that you're going to be implementing evidence-based services. That's where our people need to go. That's the kind of service that they need to do. So we're implementing a pilot in one county in New Jersey in the middle of the summer. And it's really trying to take an organization that we're going to have kind of become the quarterback for our highest need individuals, people with substance use disorders and serious mental illness. And their role is going to be really owning the relationship with that patient and that patient's family, and that they will be with them morning, noon, and night. There will be peer support 24/7 available to the patient. We have a structured outreach program where that person will be contacted at least 4 times a month from a peer. And again, the peer is there, structured outreach to make sure you're okay, and if you need help with some of the obstacles that you're facing, joblessness, homelessness, all the things that we heard about just a few moments ago, but also to make certain that you need to be going to treatment. We're going to make sure you're engaged in treatment, and guess what? If you are at, let's say, a rehab level of care today, and in the current world we live in, you're at a rehab level of care today, and you leave, and you were supposed to show up at an intensive outpatient program tomorrow. But if you don't show up, nobody comes looking for you. The program that we're trying to do is to say, let's be accountable across the board here to make sure that we embrace our most vulnerable members and make sure that they're getting the services that they need, that we are there for them, providing services, whether it's telehealth services for substance use, whether it is peer support, telephonic or in person, feet on the street, working with provider organizations, and really there's just a whole litany of things that we're working on. I've become the pilot queen. We're trying a little bit of everything because we have to find some answers. And so I'm really excited about what Horizon's been able to do and the direction that we're heading. But again, it's a marathon, not a sprint, and it's going to take everybody here to really help to make that happen. So thanks.
Thank you, Suzanne. Before I ask our next question to Special Agent Gibson, I just wanted to recognize and thank HIDER, who are also here today. Today's event is part of the DEA 360 initiative, which we're working very closely with, so we want to thank them for their support. And for those that are here from HIDER, we want to thank you for your continued efforts in addressing this epidemic. Special Agent Gibson, the DEA New Jersey Division has been in the front lines on this issue for many, many years, working in collaboration with the partnership. We've pioneered together many innovative ways to address and share information on the opiate epidemic. Can you explain the DEA's role in stemming the epidemic in New Jersey?
Absolutely. And I would just like to say thank you for having me here. And I'm just so proud to be sitting here representing the DEA and the New Jersey division and all the hard work that they've done. I cannot take any credit for it. There's wonderful women and men in DEA that have worked this problem from front to back, trying to think outside the box to come up with a game plan to help combat the opioid epidemic. I think DEA is known for the people that kick in doors and arrest people. They forget about the whole side of demand reduction, working with our counterparts in the community regarding the opioid epidemic. But I think the cornerstone of what New Jersey has expanded upon is intelligence gathering. And I'm really proud of the intelligence unit working with the state and local counterparts to obtain as much information as we can to identify trends. That is a key component of identifying threats that we know of that are happening and to try and get in front of a threat that's pending. For example, because of the opioid epidemic, we've put so much focus on that we identified that cocaine and methamphetamine are making a big comeback in the state of New Jersey. So now we're trying to figure out how to handle that and tackle that problem. But definitely we work with our state and local counterparts to include CDC. We work with them. The drug information officers that are assigned to each state are working with health officials. And the goal of that is to work in combination with other states to make sure that we're getting that information to each other, to make sure that all information that we have at our disposal is used in the right way. I think the days of working in your own silo are definitely over with. We have to work together. We have to get this information because what may be a trend that may not be significant to another component is very significant to DEA. So we have to work together on that. We've also expanded the New Jersey footprint in DEA. We realized that the center of the state was not, we needed more personnel there, so we were proud that we opened up another office in Monmouth County. We've also increased collaboration with the United States Attorney's Office, who I'm lucky to be sitting here alongside of today. We are definitely being more, we're using strict liability laws a little bit more aggressively. We're trying to streamline those so we can understand and get the probable cause that we need to arrest those that are responsible for pushing opioids, or whether, fentanyl, or whether it's pharmaceuticals, and resulting in overdose deaths. So we're really trying to streamline that process and make sure that we understand it fully. The Do No Harm symposiums with the partnership, I believe you've had about 40 of them with DEA, and you've reached out to 4,000 doctors in the state of New Jersey, which I think is amazing. I just came from the Diversion Control Division down in Washington, D.C., which was a daunting year of my life, but it was also probably one of the best experiences of my life. And nationally, DEA holds conferences. It started with the information regarding pharmacist diversion awareness conferences, where we targeted the pharmacists and we tried to give them as much information as they can to identify problems. We've converted that over to the physician diversion awareness conferences. And I had the pleasure of meeting with the head medical officer of the state of Kentucky. And he was just beyond happy about the communication that he received from DEA, that it actually changed his opinion of DEA, and that he found us more approachable, which I think we have a little bit of a problem with. But we're here to help. We're here to get the information to you. We're not out to get people. We're out to get as much information to you and target high-level traffickers that are bringing this stuff into this country. Fentanyl analogs, fentanyl are a huge problem. I traveled to China to try and meet with the government over there to try and get the whole class of fentanyl scheduled over there, regulated over there. It's a work in progress, but they met with us, and we're hoping to advance that. But fentanyl is a huge, huge problem. It's used in every drug out there. I was just asked recently, what's the most dangerous drug? And really anything that's fentanyl, anything that fentanyl is in is the most dangerous drug, and it can be put into anything. The trend right now with fentanyl is fake pharmaceutical drugs. So you could be given an oxy, which you think is an oxy, but really it's fentanyl. And I had a friend just recently, his son passed away from this. So everybody is touched. There's no one that's safe from this opioid epidemic, and everybody knows somebody that's been touched about it. So we're definitely keeping track of fentanyl. Fentanyl's in heroin. Fentanyl's making a comeback or a presence in methamphetamine, which is now called super meth. So we have to tackle this, and it's a daunting task. We're also, well, I'm very proud. My hand was getting tired. I'm very proud that in 2009, New Jersey DEA is the one who started the National Take Back Initiative. And to date in New Jersey, we got approximately 236,000 pounds of pharmaceuticals off the street. And I noticed one of your graphs, it indicated that the pharmaceuticals have been going down. And I credit DEA a lot for that, because this is nationally, and we're out there to get mom and pop, grandma and grandpa's drugs out of the medicine cabinet. And we're here to dispose of them, which is what we need to do, because they don't need to be stolen, they don't need to be given away, they're prescribed to the sole user of that drug, and we need to get that back if that drug is not being used anymore. We also are part of the overdose fatality review team, which I think is just a phenomenal idea, and because again, I can't take any credit for this, but it's basically a social autopsy of overdose deaths. And you know, obviously, it's a very private discussion, but they take overdose fatalities, they take components of different agencies within New Jersey, and they do a social autopsy of that person and that person's life. And what it is that we're trying to find patterns that maybe we can get in front of. Patterns that we can allow local law enforcement to maybe identify. So it's really an innovative way of looking at it. It started in Ocean and I think Monmouth County, that they're definitely spearheading that, and I think that's a great thing. DEA also implemented Operation 360, which puts together law enforcement, it works with the community, and it takes our diversion investigators. And all three of those entities work together to see if we can combat drug use, get it at a younger age, get the information out, and work within the communities. Different communities are identified by our headquarters, and you know, funding goes directly to that. We have youth summits, and we do town halls similar to this, and it's a great program. It's a great program to get the word out there, because let's face it, at the end of the day, we need to get to kids when they're young, and we need to make sure that they don't make that one decision. That's what we need to get out there. Don't try it, period, because that's where the crux of this problem is. You can take one fentanyl pill that's given to you as an oxy, and it can kill you. So that's where we need to get, and I think Operation 360 definitely promotes that. I just had the, hold on a second. Difficult. I just had the experience to meet our new HIDA demand reduction coordinators, and I have to say, what lovely individuals they hired. Their heart is into this. They are going throughout the state of New Jersey to get the word out. You know, the programs that they've had, they had an art exhibit, which I absolutely loved, where people that either recovering or lost somebody from the opioid epidemic, they do amazing paintings, and then we display them. And it's a great avenue to project your feelings into art. And I just thought that was such a great concept. But they're thinking outside the box to get the word out there, and I'm just very proud of our demand reduction coordinators. Another person I'm very proud of is our public information officer, Tim McMahon. He developed a program called Hidden in Plain Sight, where he goes around to schools, and he basically does a mock bedroom, and he'll hide stuff there. So it's almost like, you know, teaching parents how to find drugs that their kids could be hiding on them. And it's taken off. It got 7.6 million views on YouTube. It was on one of those shows at night, and it's spearheaded by our very own New Jersey Tim McMahon, and I'm very, very proud of that. Also, too, we also have Operation Prevention, which is at the DEA headquarters level, and it's a web-based tutorial for parents, teachers, kids. You can go on there, you can find out anything you need to about drugs, what they can do to you, and any other kind of information that you need regarding it. And I think that's a great opportunity to get the message out there. And I think one of the neatest things that I've been told about is our part of the Newark Cares program. I believe somebody is up here on that stage for it's to reach out to the education arena And if a child witnessed something the night before, whether their parents were arrested or whether they observed one of their parents or a family or a friend overdose, that school is notified. And I think that's an awesome, amazing program because it shows, the educational faculty that they know what they're dealing with when the child comes into school the next day. And it's just it allows teachers to help them through something that's very traumatic. And I don't know much about that program yet because I just got here, but I have to say I think that's one of the most innovative thing that it sounds so simple, but it wasn't done before. So I can go on. Again, New Jersey DEA, I'm very proud of the men and women there. My ASAC, Chris Yackham, spearheaded a lot of this stuff. And I'm just excited to be here and see if I can help in any way, and thank you.
Thank you, Special Agent. As you can see, law enforcement is extremely engaged in the state of New Jersey at all levels, and on the 30th of May at the Tropicana Hotel in Atlantic City, the partnership is hosting a conference specifically on law enforcement's role in the opiate epidemic, and many of the programs that the special agent spoke about will be elaborated on during an all-day conference for law enforcement. Speaking of law enforcement, the U.S. Attorney's Office is at the top federal level enforcement entity in the District of New Jersey. For Erica, how would you define your leadership role in prosecuting opiate-related cases? In what ways does the work of the Opiate Abuse Prevention and Enforcement Unit impact local communities?
Thank you. Oh, is it on? Okay, it is. Thank you, everybody, for having me here today. So the U.S. Attorney's Office in the District of New Jersey is very unique. When the U.S. Attorney, Craig Carpenito, came into office approximately a little over a year ago, he recognized the opioid epidemic that our country is facing and that our state is facing. So when he came into office, there was a reorganization, and what he did was he focused on the opioid epidemic by, we believe it's the first in the nation across all U.S. Attorney's Office, and it may be the only one, by creating the unit that I am chief of, the Opioid Abuse Prevention and Enforcement Unit. And the unit is actually comprised of both civil attorneys, assistant United States attorneys, and also criminal. And we try to attack or address the opioid epidemic on all levels. And that means our investigations in the unit run the entire gamut we have open investigations against drug manufacturers, looking at how they bribe doctors or maybe give incentives to doctors to overprescribe opioids. We have drug investigations against distributors of the opioids, so manufacturers, distributors of them as well, and also down to the doctors who are overprescribing, the pharmacies that are knowingly filling prescriptions that are counterfeit and that the drugs are actually eventually getting onto the streets. And we are also, on top of this, the drug manufacturers, the distributors, the doctors, and the pharmacies, we also have investigations into drug overdose deaths and street-level distributions of fentanyl and heroin that are causing overdose death. We work closely with the DEA and all our federal partners, agencies, including the FBI, HHS, OIG, and other federal partners. So what we do is, if we cannot establish a criminal investigation, the unit basically, because it has both civil and criminal attorneys, we run parallel investigations. So if we cannot find or we don't see a criminal aspect to something, we then go after somebody civilly. So for instance, if a pharmacy, we work closely with the DEA and their diversion investigators, they go out and they inspect pharmacies. And some of the pharmacists who may, are not careful and they are presented with several prescriptions that are counterfeit and they just fill them. They're not looking at these prescriptions closely, they're just filling them. When the DEA finds them, they bring them to my unit. And if we find that it is really just carelessness or maybe something that does not rise to a level of criminal intent, we then can fine them, with money, fines of thousands of dollars per prescription that they are filling. So in all aspects, if we cannot make a criminal case, we do also look at it civilly. Also, we also have, to address the overdose deaths, we are trying to use all of the tools that we have federally to prosecute and to enforce and to deter people from, selling heroin laced with fentanyl. In the federal laws, if there is a death or serious bodily injury by distribution, it's a 20-year mandatory minimum. So we're hoping that if we start using this statute, charging people more and more with this statute, there is a deterrence effect. And that we have seen this because we have had a case where there was an individual who was arrested who was basically importing barrels of fentanyl into the United States. We have been charging these kinds of charges, and we've seen the effect of deterrence. There was, in another investigation of ours, there was an individual who was cooperating with us, and actually, when asked why he was distributing heroin and not, other substances, he mentioned, "Well, I know, if I am caught with fentanyl and there is a death, the penalties are so high." So it's really we're hoping that if we are using these tools more, that this will eventually get out to the streets, and maybe somebody who will be thinking of putting fentanyl and heroin will think twice before they do it. So on top of it, we also are we have investigations into the importation. I think you've heard already that it's mostly coming from China. And actually Mexico as well, but the real pure fentanyl is coming from China. And the issue really is that, the Chinese, unfortunately, fentanyl is not illegal there. So that is why they can manufacture it in these laboratories that are, they're making pure fentanyl in laboratories and sending them here. So there are investigations as to that as well in the unit and also in the United States Attorney's Office in general and other units. Also, the U.S. Attorney's Office is not only about enforcement. We also have a federal drug court, which I'm very proud to be a part of. We do, when individuals are charged federally, and we find that they have a substance abuse addiction, and that their crime that they committed were driven by their addiction, we do take a look at them to see if they are appropriate for our program. And the program is dedicated to giving them a chance to, go through substance treatment and see if they can turn their lives around. And if they are able to go through the program, which is very lengthy and not easy to get through, they, instead of being incarcerated, which we find will not help them, they are given a probationary sentence, and they become very, contributing members of the community. And so the U.S. Attorney's Office, is really focused at the opioid epidemic on all levels, criminal level, civil level, and also, the small part that we can do to also help individuals who have substance abuse issues.
Thank you, Erica. Thank you very much. Our next speaker is going to speak about New Jersey specific, and I also want to, before we ask Ann her question, I wanted to just recognize Celine Levy from the Governor's Council on Alcoholism and Drug Abuse is here with us today, who's a great partner for many, many years. Since the inception in 2018 of New Jersey Cares, they've been providing real-time data on the impact of the opioid epidemic in all 21 counties. Why is publicizing this data such an important aspect of fighting the opioid epidemic?
Thank you, and thank you for inviting me to be part of this. It was a little over a year ago that the Attorney General Rabir Graywall established an office within the Department of Law and Public Safety, the New Jersey Cares Office, which is for coordinated addiction responses and enforcement strategies. And one of the very first things that he did was to establish a website that is fed on a regular basis with statistics concerning opioid overdose deaths and naloxone administrations and opioid prescriptions. I think the notion was it is important to get that message out as broadly as we can. Many of these statistics were already being collated mostly by the state police and the prescription monitoring program, but that there was a value in making that kind of information broadly available so that we can see with numbers, real empirical evidence, where we are today and where we need to be. And so we're very proud that we're getting that message out. We see it occasionally in newspaper articles and the statistics that are out there. But we mean it to be more than just sort of an alarm bell of how serious things are. And you've heard the statistics today that the opioid overdose death rate is now greater than that attributable to car accidents. It's clearly New Jersey has as significant a problem. I invite you all to visit that website at newjerseycares.gov. But you'll see that for 2018, it's been mentioned earlier this morning that more than 3,000 suspected drug overdose deaths have been reported in New Jersey. We also have more than 16,000 naloxone administrations, and that number is collected by virtue of those that are administered by law enforcement and those that are administered by EMS. It does not include the hospitals. It does not include family members who may be able to revive a loved one. But it is a good measure of what is happening out there. And we also report on a monthly basis the opioid prescriptions as derived from the prescription monitoring program. And we have seen a decline in those opioid prescriptions over the last several years, and in particular since the imposition of a restriction on acute pain prescribing to a 5-day limit. So it's important to track those numbers and to make it clear that this is something that affects every corner of New Jersey. It's not isolated, but it does help us to isolate those hot spots that really are need the deployment of additional resources, law enforcement resources and treatment resources. So working with partners like HIDA, rolling out the OD map, which helps us to really localize where things are happening. The collection of that data is so important to moving forward in a constructive way to try to address the issues. I mentioned some of the numbers that we're reporting for 2018, but it's also important to see the changes over time so that you can plan forward as to how resources should be best kept. It is also important in terms of informing public policy and those kinds of undertakings that we do with the benefit of grant dollars and those that come from our own state resources and planning those in the most appropriate way. The Department of Law and Public Safety, and one of the reasons that Attorney General Graywall created this office, touches this issue in so many of its divisions. We have a division of criminal justice, which, like the U.S. Attorney's Office, is active in this space of bringing actions. We also represent all of the professional licensing boards, so we have an opportunity to intersect with physicians, advanced practice nurses, PAs, all of the gamut of prescribers to educate what the standards should be for appropriate, responsible prescribing. And we are actively encouraging all of those prescribers to use the PMP regularly. We now have lookup mandates at the outset of treatment and every 3 months when somebody is being treated for chronic pain. I think this is not a fast solution, but overall, as people start to integrate that into their practice, I think it starts to change the mindset of the prescriber on what's appropriate, and that's one of the charges within the Department of Law and Public Safety as well. We have other divisions that may not be as integrally involved, but highway safety, juvenile justice, there are all places within the Department of Law and Public Safety where we touch on lives and we can make a difference. and the statistics help us to see where we're going.
Thank you, Sharon. Sharon spoke about public policy and the 5-day restriction for first prescriptions in the state of New Jersey. Part of that law that was passed several years ago also required a conversation to take place between a prescriber and a patient, or the parents of patients 18 and under, that the partnership was very proud to have authored. That law was really an education law that provided this very crucial information at the time of first being prescribed an opioid. That law now, which was the first law of its kind in the country, has now been adopted in 10 other states, and there are another 8 states that are right now, it's in the process of being adopted, and it's being heard in different legislative hearings throughout the country. So we're very proud of what we've been able to do in New Jersey and how it's being replicated throughout the country. So we want to thank the state for their continued efforts. We also have with us Kingsley Adu, who is from the New Jersey Department of Human Services, which I know also plays a major role in many of the initiatives revolving around the opiate epidemic. So Kingsley, thank you for joining us today. We're going to now bring it back to the federal level. We have with us Ann, who speaking about the ONDCP's mission, and in particular, how do we engage rural communities to take action against the opiate epidemic, and also equip them with the resources they need to address the crisis.
Thank you. Are we on? All right. Well, good morning, everyone. It's great to be with you. Thank you for that question. Our mission at the Office of National Drug Control Policy is simple, and I would guess that it's shared by many of you in this room, and that is to save lives. And when we step back and look at some of the numbers that Dr. Noonan showed in her slides this morning, we think about the number of people that are dying each day from the opioid epidemic. Many of those deaths are happening in rural America, in small towns and rural places. Here in New Jersey, and I was in Washington State yesterday, so this is not an issue with respect to rural that is concentrated in a particular region of our country. I think many people often think about drugs as being a big city issue, and that just is not true. Back in 2014, I'm from Indiana. There's a county in the southern part of the state, Scott County, Indiana, that made national headlines. They had a massive HIV outbreak due to injection drug use. We fast forward 5 years later, and that scenario is not limited to Scott County. Just a few facts and figures to shape this for you. Those wave of epidemics that Dr. Noonan showed in her slides, if you go back to 1999 and the time that we see between 1999 and 2015, drug overdose deaths in rural communities rose by 325%. And back in 2017, 2 leading farm organizations, the American Farm Bureau and the National Farmers Union, not 2 stakeholders that are typically involved in drug policy, did a survey because they were hearing about this issue from their members. And that survey revealed that nearly 50% of rural Americans have been directly impacted by opioid abuse. So with those numbers, we know that this epidemic is impacting families from all zip codes of this country. And so to meet that mission of saving lives at our agency, we know that we have to be engaged with rural America in this crisis. As we really see our role as being a partner in action at the federal level with state and local communities. So as we step into that role in rural, the president, all of the members of the cabinet, our leader, Director Jim Carroll, the president's drug czar, all understand not only is this having a massive impact in rural America, but as importantly, we know that there are gaps that are unique to rural communities, that when that need arises, the needs look very different than they do in an urban center. In a rural community, you will not see some of the critical assets that we often need to respond to this crisis. Things like treatment centers, transportation to get to services, and in some parts of the country, lack of broadband, that internet that we need to provide response through technology. So as we come alongside state and local leaders at ONDCP, we really have 3 lines of effort, if you will. First, how do we prevent people from getting on these substances in the first place? So a heavy focus on prevention. Secondly, how do we help people who are struggling with addiction to get access to the treatment and recovery services that they need to get healthy and stay healthy? And then lastly, how do we reduce the availability of illicit drugs in this country? Much of what my partners to the right here have discussed in law enforcement. So as we take action then on those 3 priorities in the context of rural, we have 3 areas of focus at present. First, I mentioned many of the needs that we see in rural communities here in New Jersey and beyond look different than urban centers. We see gaps in infrastructure for prevention, for treatment and recovery. In many small towns, there's not quality housing for recovery residences, for example, and that has very real consequences on the number of lives saved. So we're taking action, working with several of our other federal agencies to really fill many of those gaps. I want you to be aware of a resource. Many of the programs that can help address these issues in rural communities actually come from the Department of Agriculture. And here in New Jersey, our leader for that team is Mr. Ken Drews. Ken, can you stand just for a second? Here in the front row. If you've not had an opportunity and you're working in a rural area to connect with Ken and Jan and our team, I would encourage you to reach out to them today. There's a lot of programs there that might be of assistance. And I think what's important too, in addition to what we have for prevention, treatment, and recovery, in many rural communities, there are longer, deeper systemic issues that are happening in these places. Lack of economic opportunity. There's a number of business programs as well that can help revitalize many of these communities, and so that is an important contact you should make. So in addition to meeting those needs, we're very focused on trying to increase access for rural communities to many of the existing resources that are already here. Most small towns don't have a grant writer on staff, and just knowing where these programs are and having the capacity to go and access those resources is a great challenge. So last year, our leader, Director Jim Carroll, created a Rural Opioids Working Group, and this was an effort to bring together 12 different departments and cabinet-level agencies that all have resources to help fight this epidemic in rural communities. The first product that came out of that work group was a rural resource guide, and we will certainly be building off of that momentum, again, for that local mayor or county commissioner who's maybe doing this job part-time, knowing where to go and find those resources and help his community to apply. In addition, we've already heard today a lot about data, and we know data is so important for local leaders to be able to make strong decisions. So we undertook an effort last year to build a community assessment tool. It covers every county in the nation. Local leaders can go on and see data that might be in their county for overdose deaths, but overlay that with some of the socioeconomic things that might be happening in the area. So it's overlaid with data about poverty rates, unemployment, education levels. There's a lot of information there, and all of this can be found on a website that we have. It happens to be on the USDA. It's a webpage on the USDA website, usda.gov/opioids. And we'll be looking not only to disseminate those tools more widely into communities, but to build additional tools to respond to the needs of rural communities in this fight. Lastly, in addition to that infrastructure, that partnerships, that tools piece, we are very focused on how can we drive greater innovation at the local level in helping communities to respond. Certainly no two rural communities are the same, but we know that what's working in one place is something that another community may be able to replicate. So we have very focused on finding those success stories by holding roundtables, just like what the conversations that's happening here today, and learning what's working in one place and being able to share that out in another. We've built an interactive map on that USDA opioids webpage. In addition to that, we're producing a community action guide that will be revealed later this year, and again, represents solutions that we've heard about on the ground, as well as many of the lessons learned from our partners. So I'll just close with the notion that I know you've seen here firsthand here in New Jersey that the scope of this issue and the complexity of this issue requires us to do things certainly in a different way. So with that reality, we are committed to making sure that the needs of rural America, rural New Jersey, are elevated in this discussion and are met. Thanks for having me here today.
Thank you, Ann. Thank you so much. And New Jersey is still the Garden State, so we certainly need that advice and help. Next question is to Dr. Ferrari. We know prior to being appointed as the Regional 2 Director of HHS, you had most recently served as an advisor for initiatives to address the opiate epidemic in your native Staten Island. What are the best practices for HHS recommending to local communities to help them address the opiate crisis?
Thank you, Angelo. And on behalf of Alex Azar, the Secretary for Health and Human Services, my compliments to Alan and Horizon Blue Cross Blue Shield Foundation, and of course to Angelo and the partnership. It's interesting. I've had an opportunity. I am not a political person. I come out of the healthcare industry, and I spent 40 years working in hospital administration, starting my career as what they then called Director of Personnel before it was referred to as Human Resources. In fact, that career started at United Hospitals in Newark, which is no longer a functioning hospital. But I had the opportunity to work in the inner city and learn a great deal about the healthcare needs of people in the inner city. My career took me through a number of places, to Vice President for Human Resources at St. Barnabas Medical Center in Livingston, New Jersey. And eventually, I wound up as the president and CEO of Staten Island University Hospital. Now, the reason that I mention that, Staten Island is an interesting community. It is an island, obviously, and it is a community of 500,000 people. If we're a city, it would be the 37th largest city in the United States. However, Staten Island doesn't have its own Department of Health, its own police department, its own mayor. It actually is a small part of the city of New York, being the smallest borough of the 5 boroughs in New York City. However, Staten Island, unfortunately, within the city of New York, has the highest rate of obesity, highest rate of lung cancer, highest rate of breast cancer, highest rate of smoking, highest rate of heart disease. And with no public hospital in Staten Island, by the way, the other 4 boroughs in Staten Island each have at least 2 public hospitals. So with no public hospital in Staten Island, a community of 500,000 people, the private not-for-profit hospital becomes the de facto public hospital of that community. Now, that places a lot of responsibility on the president of that private not-for-profit hospital because he becomes the de facto head of healthcare in that community. And what I learned after 40 years in healthcare, finally having retired out of the Northwell Health System and retired as the president and CEO of that hospital, after spending a lot of time sitting on the couch and watching MeTV, I decided that I picked up the Daily News one day, and the cover story showed a mother on her knees in front of a tombstone at Resurrection Cemetery, which is a large cemetery on Staten Island. And the story in the Daily News was about these 8 consecutive grave sites that had all been, deceased had all been placed in a period of about 10 days. And those 8 consecutive grave sites were people, all people, who had died from drug overdose. This is Staten Island. I called my close friend, the borough president of Staten Island, Jim Otto, and I asked him if it was possible that I could volunteer my time working on the opioid crisis in Staten Island. After joining him, and he graciously agreed, after joining him, I reached out to the Bloomberg School of Public Health, to Dr. Josh Sharfstein. Dr. Sharfstein was formerly the Commissioner of Health of the City of Baltimore, and later on the Commissioner of Health of the State of Maryland. While at the Bloomberg School of Public Health, he embarked on studies across the United States, which I'm sure Dr. Noonan is familiar with. And by the way, the map that Dr. Noonan had shown behind us that showed the hotspot counties in the United States, one little red speck off to the right side was Staten Island. I contacted Dr. Sharfstein. I had seen that he had done similar studies, data studies, in West Virginia and in Rhode Island. And I asked him if he would be interested in conducting a study in Staten Island to determine what things really matter in the terms of the fight. And if you look at the presentation that Mr. Booker said, Senator Booker, he said that he was looking for funding things that really work. The purpose of the study is basically to take all of the initiatives, because Staten Island was in a crisis. The purpose of the study was to take all of the initiatives that were being done, and there were so many, and a great deal of resources and time were being spent on all of these initiatives. The purpose of Dr. Sharfstein's study was to come to Staten Island, study the data, and identify those initiatives that really matter, the things that really matter, the things that really work. So it's true exactly what Senator Booker said. We really want to concentrate resources and funding on the things that really work. And Staten Island is an interesting place. I've worked in the inner city, Staten Island, considering all of the health issues that it has, leading the city of New York, unfortunately, in so many diseases. The fact of the matter is that Staten Island is a middle-class, white-collar community with many, many city workers residing in Staten Island. So you wouldn't tie the two together where you have a middle to upper middle class community, where you have a prevalence of all of these diseases, but especially where you have a prevalence of deaths due to overdoses. Now, when you take a look at the statistics, one of the things that Staten Island leads in the city of New York, and probably in the state of New York, is that there are 300 opioid prescriptions written for every 1,000 people on Staten Island. Think about that. Think about the access to opioids that exist in that community. And if you study a lot of communities that are hotspots, a lot of counties that are hotspots, I think you will find the same thing, a large amount of prescriptions for opioids in that community. Staten Island is a very interesting town. It is something that, with the information that we received from the studies performed by Dr. Sharfstein, Staten Island was able to implement and concentrate on those things that really do matter. And as a result, we have started to see a decline in the number of overdose-related deaths in our community. Just a few weeks ago, I received data from what we call headquarters at Health and Human Services, the Office of the Secretary, identifying by each region those counties that are hotspots and those counties that we should be concentrating on. And I found it interesting, but not surprising any longer, that when I looked at the counties, there were 3 in New Jersey, and in the entire state of New York, there were 2 counties with the highest rate of overdose deaths. One is the Bronx, and the other one is Staten Island. So that dichotomy that exists, going into a county with a low economic status, going into a county with the highest household income, and the two of them, the lowest household income and the highest household income, have the highest rates in the state of New York in terms of opioid overdose deaths. This administration and the Secretary are committed and have committed $2 billion to the fight against the opioid epidemic. One of the slides that I found very, very interesting, in the information that I've seen, one of the slides that I found very, very interesting was a graph that showed the total number of deaths from World War I, World War II, the Korean War, and the Vietnam War. We have seen more deaths since 1999 in this country due to opioid overdoses. That is a shocking revelation, and we need to do something about it. The Secretary has 4 priorities that he announced when he became Secretary of Health and Human Services. Cost of prescription drugs need to come down. We need to take a look at the transformation of health care to value-based care. We need to bring the cost of health insurance down. But the most important priority of all that Secretary Azar has is dealing with the opioid epidemic that this opioid crisis that this country is facing. So with that, I'd like to turn now to the 5-point strategy to combat the opioid crisis. Again, this is the 5-point strategy by Secretary Azar. Better addiction prevention, treatment, and recovery services. 2, better data. 3, better pain management. 4, better targeting of overdose reversing drugs. And 5, better research. And if you take a look at the study that was done in Staten Island, the results that Dr. Schofstein had determined, and you look at that report, you will find all 5 of these points mentioned in his study and his report. So with that, thank you very much for your time. I do appreciate it.
Thank you, Dr. Ferrari. Thank you. Okay. Our next question is for our keynote, and it's a quick question, but I think an important one. What do you think is the most pressing concern about this crisis today? I mean, what really stands out as something that everyone in this audience could take home?
Again, thank you. And am I on? Thank you. Great presentations. This was really, really lovely. You know, there's so many things, and I think that every person here has touched on something that's critically important. So I think it's very multifaceted, but for people sitting in an audience like this, I don't know what your professions are, or I think everybody probably does know somebody and can do something perhaps within your profession, but in your personal life. I do think that trying to reduce stigma and understand the problem and trying to help people understand where services are and link to them, I think is something that is very, very doable for anybody in this audience. And, you know, having said that, at the same time, I think all those things, data, you know, targeting interventions is very important. When I go into communities, and I've worked in many different parts of public health, I used to work in violence prevention. There's a lot of, I think there's just a lot of homegrown ideas about, well, let's do this or let's do that, or I want to do it my way. And I never want to squash innovation, but at the same time, I really, I think it's important to harness what is known to be working. And I would encourage everybody to try as much as possible to follow the evidence. You know, the evidence is, you know, the backbone of CDC and science, but I think that some things are much, much more likely to create the outcomes that we're looking for than other kinds of things. So multifaceted, but in your job, in your life, I think that reducing stigma and following the evidence about how people can get help and get care, I think would be really, really important.
Thank you, Dr. Noonan. Thank you. We're now going to be opening up the questions to the audience, and there are 2 mics, one on either side, if you'd like to come up to the front mics. And while we're doing that, we have some questions from those people that are watching live stream. We have a question from Sherry from Bridgewater, and this could be to any of the panelists. She asks, we need more local inpatient rehabilitation resources. Can we expect to see this soon? Does anybody want to answer? Sure, Susan.
I might turn that just a little bit. First of all, there are so many levels of care that are available out there for individuals who are suffering with opioid use disorders. The state of New Jersey has funded, in this past couple of years, I think, when the Christie administration had put a lot of different mandates in place, and one of that was opening up over 1,000 new beds in this state. My personal opinion is I'm not so sure that our only solution is an inpatient solution. I think what we need to do is really focus on the community. We need to keep people in the community and know that there are services that are available to them right in their backyard. One of the challenges I see is if I'm a parent, and if one of my kids I saw was struggling, I'd want to go online, just like I do for everything else, to say, hey, I need cardiac surgery. I know I can go online and I can find out that the best place to go in the region is, I don't know, Columbia, for lack of a better word. But if I have a problem with my child on having a substance use issue and I go online, I'm going to get a litany of 800 numbers. There's no standard of care, in my opinion, across all these levels of care. How do you know, even as an insurer, how do you know where's the best place to send somebody for services, whether it's an inpatient bed or if it's an outpatient program or something even more focused in the community? We don't know, and that's one of the greatest opportunities, I think, as an organization that we have to try to help to change the dynamic. We're working through the Blue Cross Blue Shield Association, who is working with all of us local plans to come and to work with experts in the field to define what is success, what does it look like? So we could say, if you go here, I know this is what I can expect the outcome to be. It's more than just how long did you stay, how many readmissions do you have. There's a lot more to this, and I think we owe it to ourselves and to all the people in our community who are suffering to make something happen there. We're also working with an organization called Shatterproof. So if you have an opportunity to look at Shatterproof, if you haven't heard about them, it's started by an individual named Gary Mendel, whose son committed suicide at the age of 25 as a result of not being able to deal with his opioid use disorder and the impact it was having on his family, et cetera. Gary took money out of his own pocket to start up this organization, and may not be the most popular thing out there from a treatment community perspective, but Gary is committed to setting up a rating system for these types of treatment organizations. And there are 5 states that are in the pilot stages right now to define what does quality actually look like, what are the outcomes we should be looking for. So in terms of, if I were writing out of my own personal checkbook, I'd be putting money in the community, but again, there's a place for everything.
Okay, thank you. Our next question comes from Dr. Paul from Mount Laurel, who's also watching today's summit. Can you please explain the advantages of non-pharmaceutical and non-opiate options for pain management? Does anybody want to address that issue about alternatives to opiates for pain management?
I don't mind taking one quick first crack at it. You know, the CDC guideline, part of what we did, we combed through literature. We looked at systematic reviews that have been done by all kinds of, academics. We also talked to communities. We had public comment periods. But in kind of going through all of the paces to make sure we were really careful, we looked a lot at what the evidence and science says about alternative treatments for pain. And there's pretty good evidence for exercise-type therapies, which in the past were perhaps more common, but they are a little harder to execute if you're a healthcare system because you might be paying for more sessions of, say, physical therapy or something like that. So there might be cost implications, but I think for all the insurers and systems in the room to really think about what are safer alternatives. Some of them might require different kinds of coverage, for example. But so exercise therapies, physical therapies, cognitive behavioral therapy, those actually have a strong evidence base. And just, as a side note, I couldn't say everything I wanted to about, pain or the CDC guideline, but there are indications that, for chronic pain, opioids are not even necessarily all that helpful and can make people experience more pain. So the growth in the marketplace for opioids was driven largely by chronic pain conditions. And what we're learning now is that opioids aren't necessarily a very effective treatment for that kind of condition. So I would encourage any of us and all of us to really think about, getting to that point where physical therapy, and whether it's reimbursement or whether it's something that any individual patient can pursue, that there are alternatives. And those are just some. So that's my first crack.
To that, from a rural perspective, there has been a lot of focus on building those alternatives, and I think as we do that, we need to make sure that those are available in all parts of the country. In rural communities, you don't have things like a PT clinic or a chiropractor or other options that you often don't have those resources in the way that you might in an urban center. And I think that's one of the reasons that you see prescribing rates are typically higher in rural America than they are in urban centers. So as we continue to work together to define those alternatives, we will be advocating to make sure that those options are truly available in rural communities, whether it's the construction of a facility or finding a way to deliver them in a more innovative way through telemedicine or through mobile delivery of services that we see in states that are more remote than New Jersey.
Thank you. I think we have a question here from the audience.
Good morning. My name is Pam Coles. I'm a volunteer with Partnership for Drug-Free New Jersey in Bergen County. And my partner and I, Marge Deanna, we go to all the local football games, reaching out, doing outreach in various, at our football games. And we have 70 towns in Bergen County, and at those points in October and September and October, those are the busiest times, along with our alliances. And what we do, and I want to thank Angelo for giving us the opportunity to be able to be volunteer and the voice, Marge and I are the voice in the Bergen County for Partnership for Drug-Free New Jersey. And we have our young folks, so my question is twofold. We have our young folks working with our SACs, going out and distributing the material in their local schools. So the first part of my question, I believe, might be directed to you at Horizon. What is the duration of time that someone needs to get off of heroin and the opioids?
To say everybody's an individual and it's going to be however long it is. To be very honest with you, that is the right answer. But we're looking at programs now that are looking at 12 to 18 months long to make sure that not only are you getting the treatment that you need in the most urgent points along the way, but all the support services you need in addition, like the counseling and the therapies and support with getting a job, a place to live. We're actually looking, we're paying for things now that we never paid before, because we know that the only way to keep people healthy and avoid long-term expenses is to really do the right things now. So we have patients that we actually just contracted with an organization for the peer support, and we expect that everybody that's going through that is at least a year in. We also have other programs where we've got 8 to 12-week telehealth sessions, but we also committed to up to 52 weeks of support beyond that. And it's not just one answer, it's a lot of different things in combination. But we know that some people will forever be on MAT, some people will taper off, that's hopefully where we'll get to, but it's a long duration. And as I was saying before, it's a marathon, not a sprint in terms of recovery.
Thank you.
Thank you.
And my second question is, we bring a lot of our programs into the schools. So we're working directly with the schools and the local school areas. What I'm beginning to see is that we need to speak the students' language. There's a few programs out there. One of them that I know of is an Alive program for people who have been addicted to heroin and have come off, who are now in recovery, and they're going into the schools, and they're 20-somethings. So it's their personal experience of what it's like to be addicted to heroin and what it took, the God amount of time and effort and energy along with their family support. So I want to, what are we doing inside of this school, reaching out to the schools and speaking the students' language? Listen, I could be preaching up the wazoo, right? And people won't listen to me. When I reach out to the schools and to the students to have them speak their own peers' language, there's a greater understanding. So I want to know what we are doing to reach out to them.
Yes, go ahead, please. Thank you, Pam.
And I already talked more than everybody else, so I apologize. But I want to say something a teeny bit unpopular, and I hope nobody streaming gets mad at me or goes and tells my boss, but just kidding. I'm not going to say anything that bad. A little unpopular, I want to say that there are very well evaluated school-based programs that sit in this space for either delaying or completely preventing experimentation or early initiation, we might call it. There are actually programs that exist already. There are registries of such programs. They might be universal school-based programs, what we might call it in public health, but I know SAMHSA and other parts of HHS, you might want to speak to this. I would caution us against reinventing and doing something that's completely homegrown, but to capitalize on what is known, where the evidence exists, and then you can tailor it and adapt it with perhaps different kinds of spokespeople, or maybe there's events around it. But I've seen a lot of, and again, coming from violence prevention, I've been doing this work for probably 20 or 30 years. I've seen a lot of wasted effort on things that have no evidence, no evaluation behind it, and I would just caution us against doing that, and that, if you must, you can, adapt something to meet a local audience. So that's my spiel, but only because I'm frustrated after 30 years of doing this kind of work that I still see a lot of mistakes, I would call mistakes, being made in communities. So sorry if that's unpopular, but I had to say it. Do you want to say anything?
Yeah, thank you. And tied into that, and I'm sorry I keep talking about Staten Island, but I know it better than anything else. And if I had my way, we'd be part of New Jersey anyway. We tried to secede, but that didn't work. And that's very true, Dr. Noonan. And part of asking Johns Hopkins to come in and to work in Staten Island was so that they could gather information. There are a couple of programs in Staten Island that deal with just this issue. One is TISA, which is Tackling Youth Substance Abuse, and that covers from age 10 to age 25. And the other program is a Too Good for Drugs program. Now, that program started before the Johns Hopkins study, and it involves law enforcement. Staten Island DA also has a law enforcement diversion program, similar to what you talked about earlier in terms of in this case, not prosecuting people with addiction issues who have low-level crimes, and working with them to get them into treatment. The Too Good for Drugs program is similar to what you're talking about, but it utilizes law enforcement with police officers actually coming in and talking to children in the 3rd, 4th, and 5th grades, and talking to them about the perils of drug addiction and the impact of drugs. Now, part of what the Johns Hopkins study did was to take a look at what was being done in the classroom as well. And while it's too early to tell, because we have to wait until they become adults or adolescents or later on, it's certainly their indication was that these programs can work if done properly, and that they support it, and the federal government also supports, as part of the prevention and intervention programs, education. And so to a certain extent what you're saying is true, but jumping into something before you actually have the evidence base to introduce programs, and again, getting back to what Senator Booker said about funding things that work is so very, very important. Thank you.
Thank you. I think we have a question on this end here. Okay. Thank you, Pam.
This will be very quick. My name is Dr. Wazak. I'm representing Felician University School of Nursing. And I was just curious about carfentanil in particular, with it being such a strong, very potent opioid for healthcare professionals, especially working in the emergency room. Are we seeing this in New Jersey? And we certainly would want to be careful dealing with handling patients who might have it on them.
We are seeing some of that in New Jersey, and some of the other fentanyl analogs as well are showing up in the drugs that are seized after an overdose or after an arrest. And, tracking the new analogs and getting them rescheduled, there is a mechanism to do it, but it's not a particularly quick one. So, it's important to stay abreast. And the state police, they have a drug monitoring initiative that really is terrific at gathering evidence of that sort.
I could just say quickly, too, that it is an issue here, and it's an animal tranquilizer. That's where it's been used at. And here we see, it's essentially, in my mind, almost a death sentence. Carfentanil is pretty much going to do you in. And when you look at, I know the DEA had a slide in a presentation I saw in terms of, here's how much heroin you would need to get a high. Here's how much fentanyl that you would need. And then when you get to carfentanil, we were talking like 1 or 2 grains, and that was it. So it's here, and it's terrifying.
Thank you for that question. I think we have a question here on this side.
Could I
just add one
Sure.
thing? It is also true, I think, that a lot of the people who have taken something are not always aware that it is laced with fentanyl or has fentanyl in it, and that too is causing overdoses because they're not used to the doses that contain that substance.
That was one of the questions we received online, which I can add at this point, is regarding the strips that might be available to identify fentanyl. Is that something that is being explored as an option for distribution?
There are presently 7 syringe access programs in New Jersey, and my understanding is they do provide fentanyl test strips.
Test strips,
And
yes.
I would like to say
It'll come on. They'll put it on.
I would like to say that DEA has also, within the past year, we scheduled the whole class of fentanyl. So it was a big step forward in regulating fentanyl and keeping track of it. So even if you change one molecule of fentanyl, it's scheduled now. So that was a big win for DEA.
Thank you. And the partnership also has a public awareness campaign right now on fentanyl, and just to alert the public and to allow the public to become engaged in understanding what fentanyl is and how they can help protect themselves. John?
Members of the panel for taking the time out of their busy days to come here for this summit. In addition to having the honor and privilege of being a member of the Board of Trustees for some years for the partnership, in my day-to-day life, I'm also a criminal defense attorney. And I want to not put you on the spot, Erica, but direct this question to you. And I want to preface the question with just a brief comment and an acknowledgement. I think the U.S. Attorney's Office for the District of New Jersey should be commended for leading the way with the establishment of the federal drug court program, which we as criminal practitioners know has been available on the state level in New Jersey for quite some time, but New Jersey is the pioneer in the federal level in establishing that program, and I think they're to be commended. And my question is, and perhaps because I have an opportunity to see from this side of the federal criminal justice system what I once saw when I was in your seat many years ago as a federal prosecutor, we get a different view of things when we represent individuals. And as successful as I think the program is and can be, I think there's one step further that it can go, and that is the following. It's my understanding that in the program you have to enter the plea of guilty. You serve your 5 or however many years it is of a probationary term, which is a very strict supervisory term, all to be understood when you're treating someone with that addiction. But then the conviction stands on that person's record. And I think that part of the multifaceted approach of that person reintegrating back into society and becoming a productive, successful member of society includes employment. Many of the people come to your doorstep homeless, jobless. To coin an old phrase, idle time is the devil's workshop. And so if these people get out, particularly those with no prior federal criminal record, because the great distinction is there's no expungement mechanism to expunge a crime on the federal level. There's just no such statute. And I think it would be a little bit idealistic for me to think we can convince Congress to pass a federal expungement statute to address this problem when I think it could be addressed quite logically and practically at the local level in New Jersey by not insisting on the entry of the conviction. You can have the person plead guilty like they do in the state of New Jersey, hold that conviction in abeyance, don't enter it as a conviction. If that person fails the drug program, well then, obviously, by all means, they know the circumstances and you can enter it. But if they succeed and graduate from the program, it's somewhat counterproductive to leave that blemish on their record when they go for a job and they have to put down, have you ever been convicted of a felony? And as we talked about the stigma of being an opioid addict, right, or a drug addict, imagine the stigma of former clients of people in my, or current clients of people in my shoes when they say, Can you imagine I'm applying for a job, and not only do I have to disclose I have a federal felony offense, but it's for narcotics distribution. So with that heavy, long-winded background, my question is that something that has been considered by the U.S. Attorney's Office in the implementation of the drug court program, and has it been a decision made to not pursue the avenue of, that I just discussed, that the state pursues to allow that person to not have a conviction? And if so, then what are the reasons why, if you know, that they've decided not to adopt that approach? And if not, do you think it's something that they will consider going forward with the program? Thank you.
Thank you, John. Yes, Erica.
John, that's really is it on? Okay, John, that's really putting me on the spot. But so I will have to say that the conversation about someone not pleading guilty and not having a federal conviction has never really been discussed. So I will say this: you are caught in the federal, if you are arrested and charged in the federal, with a federal crime, it is a high-level crime usually that you're caught up with, right? We don't, the federal authorities, we really don't arrest the user, with a small amount of drugs. You're usually not charged. So these individuals who are charged federally are facing, they were charged with serious, crimes. Most of them, sometimes they are in the drug distribution and caught with a significant amount. And so to go to your question is that we don't actually see, the break that they get is probation. So probation is very rare in the federal world. It's more common in the state courts and maybe municipalities to get probation. Federal convicted felons very rarely receive probation. So what the benefit they get for getting into our pretrial opportunity program, which is the formal word for our drug court, the name of the program, is that hopefully they are facing probation. And so through the program and my involvement in the program, I've seen actually all of our participants do have jobs, and they are able to, maneuver around. We do recognize the federal conviction is an issue, and they are limited in the types of employment that they can probably receive later on or gain. But for instance, we had a pharmacist in our program who, he speaks publicly now. He's now has gone through the program and graduated successfully. But he was, when he was arrested and charged federally, he was a pharmacist in a hospital that was taking out, with syringes, opioid drugs, painkillers, and replacing it with something else. And he was charged. That's a very serious, crime with a lot of health issues and possible dangers to the public. So he was charged, but he went through the program, and a lot of the individuals who actually go through their program, actually, it sounds unbelievable, but they're very thankful that they were actually arrested by the federal government and given the opportunity to go into the drug court program, because we do have a lot more resources. It's a smaller program. There's a lot more resources available, and kind of the kind of support that we give before they are released or graduate from their program. So, for instance, so that particular individual, although he lost his pharmacy license, when he was graduating, he was looking to get his pharmacy license back. It wasn't this. I don't think the federal conviction actually was a complete bar for him to get his pharmacy license back. He chose not to, however, and now he is kind of doing, running treatment centers and that much and giving back to the community. We also have another individual who was a nurse, and she also had lost her license, but she is actually also, I believe she might have gotten her license back too. So I don't know. So unfortunately, no, we don't consider not the plea. Would we ever consider it? That's probably something above my pay grade, and something that I'm sure that we would consider if we saw that it would be beneficial, or some kind of, if it was a huge barrier to individuals getting their lives back on track. I'm sure the U.S. Attorney would consider it. I don't know if that would be something that would really happen at the end of the day, but it's something that, of course, we would consider. But at this point, we haven't really seen it as a huge barrier for individuals to regain and kind of reestablish their lives.
Thank you.
It is encouraging to hear that you will consider this on those exceptional cases. Thank you.
We have one more question that we're going to be able to take, and then I know the panel will be here for those who want to ask questions to them directly for a few moments after the program's over. Again.
My name is Teresa. I'm a pharmacist for 32 years. I have a question for Horizon. We see a lot of our customers coming in and getting their prescriptions 5 and 6 days early, leading to numerous amounts of pills extra in their home. We want to know why that happens for them, yet people that are blood pressure medication they can't get but 2 days early. We struggle with that because some people can take anywhere from 10 to 12 pills a day, 5 days early. They now have 60 extra pills. And that's what we want to see as a change. If you can let us know.
To talk to you further about this after we are through here. We do have a very, very active pharmacy program, though. Actually, the one thing that I was most impressed with when I first got to Horizon is that they started doing some of the early work on opioids in 1999. So I was really very impressed by the work that the pharmacy team has done. We have a lock-in program right now, for example, for people who are doc shoppers and pharmacy shoppers. So I think we've got over 6,000 people that currently now are restricted to one doc, one pharmacy. I know there are programs that I know that our team is looking at, overutilization, underutilization, kind of what, so I don't know specifically the ones, so I'd be happy to talk to you about that, but I know that it's a real aggressive program in terms of trying to manage all that.
We see that they have to be specific to pharmacies, doctors, sign contracts, but when they come to the pharmacy, they walk in and want to know why we can't get the drug, but the insurance says we can. So they're walking out with extra meds that they can easily take too many of, give them away. That's where we struggle.
Well, what you're saying is absolutely right. We're struggling with that too, so I want to know more details from you. Thank you.
Thank you. We do have one last question, which we're going to ask each of the panel to spend just a moment, and then we're going to conclude the program today. And it's a very important question. It's given the multiple sources of federal and state funding to address the opiate epidemic, what mechanisms are in place to ensure that different federal and state departments are leveraging their collective resources and not working in silos? So I think that's a very good question to conclude today's conversation, because we talked about cooperation. So would someone like to begin that? Yes.
As I said before, intelligence gathering, working with your state and local counterparts, it's a priority right now. In the state of New Jersey State Police, I have to say, leads one of the most robust intelligence gathering entities right now. And we work closely with them. We provide them information. They provide us with information. And the 21 counties in New Jersey are quick to get to provide information to the state police. So, you know, they do it right, and it's a very vast network that they have right now. But I also think the Drug Intelligence Officer program is critical, so the states can talk. So it's not only just the counties talking to one another; it's the states.
Excellent. Yes, Erica.
Also, if I can add, so the federal, the state, and the local, we are all talking. I think everyone recognizes that we can't operate in silos in this space. So, for instance, we've heard a lot about the state police and the drug monitoring initiative. So they talk to, the U.S. Attorney's Office too. All the information that is pushed out to the local law enforcement, the county prosecutor's office and the state AG's office, the U.S. Attorney's Office gets it too. So we monitor on the U.S. Attorney's level. We also see all the, the heroin stamps and the clusters that are happening. And if it's more than one county, and we do reach out to the counties to see if we can help in the prosecution, if our laws are stricter. that maybe we federally adopt a case and take it federally to hopefully that then we can, spin up and go to a supplier in the higher level is our goal. So there is a lot of conversation. We work closely with the state AG's office, county prosecutor's office, and even on the prosecution level, not even on the law enforcement level, but on the prosecutor level too.
And from a policy perspective, there's a lot of conversation going on between the agencies, state agencies. As the notices of grant funding come out, it sparks a conversation between the potential agencies that may be in the best position to advance that, often with another agency as a partner. We've got a couple we're looking at right now. But we are coordinating at different levels with particularly Health and Human Services.
From a rural standpoint, I talked about some of the coordination that's happening in the government side of things with that federal rural opioid work group and some of the product that's coming from that. We also have some targeted agency partnerships working with Department of Justice on getting more drug courts in rural areas, working with the folks at SAMHSA on transition housing. A point that hasn't been mentioned yet that I want to leave you with respect to partnership and coordination is what's going on with all of the different stakeholder groups, whether we're talking at the federal level, the state level, or even in local communities. I think the nature of this issue, people just want to do something, and oftentimes they jump out and they're doing something and it ends up becoming isolated. And so a role that I've been playing is to try to pull all of the rural organizations together that are working on this issue once a month and just get them in a room. Sometimes we're sharing information to them, but a lot of times it's just to get them hearing from each other what they're doing. We pull together the Sheriffs, National Association of Counties, Farm Bureau organization, but I think that can also happen at a local level, and you don't have to have a government leadership position to do that. You as a core stakeholder could just be noticing who else is working in this space, and once a month, let's set aside a half an hour where we get everybody together, even on a phone call, to know what's going on, because everyone's so busy, it's easy to become siloed and not intentional.
Excellent suggestion.
And within the federal government, within HHS, of course, to avoid the possibility of silos springing up, there are a lot of agencies, a lot of divisions within Health and Human Services. And in this particular area, the one that is coordinating the greatest amount of funding is SAMHSA. As the regional director, and in order to keep the flow of funding and keeping the flow of information going across the nation, HHS is divided up, as many agencies are, divided up into 10 regions. As indicated earlier, I am the regional director for Region 2, which is New York, New Jersey, Puerto Rico, the Virgin Islands, the 8 tribal nations in New York State. And in terms of what we do is that we meet on a regular basis with the other agencies because SAMHSA is divided up into regions. Right now, the regional director for SAMHSA is responsible on an acting basis for other regions across the country, so he's a very busy individual. But part of what we do is that we share information. SAMHSA is sharing information with other agencies. We are then sharing that information. Part of my job as regional director for HHS is I work with state government. I work with local legislators, local governments, in sharing that information with them of things that are available so that it just doesn't sit in one place. So there could be silos even within one federal department. We want to make sure that that doesn't happen. And I think the structure that we have in HHS is doing that in many parts of the federal government. Thank you.
Great. Just real quick, we're part of HHS, so I just wanted to put in a plug for the point that was made here, and I wanted to say this regardless. There's a process of engagement on the opioid issue that's called RxStat, and it was popularized or really created from New York City when they had the CompStat, which was a crime-fighting way of sharing information. And the whole notion was what gets measured gets done. And they get all the people around the table to say, let's agree on, we call it our North Star. Let's agree on what the goal is. Let's have every agency that touches on this meet once a month, and we look at the same indicators for the same goal. So if your goal is the prevention of overdose deaths, you're going to look at data from public health. You're going to have your prosecutors and all kinds of folks who are in the room. And that process to me is really, really helpful. And any community could do that. So Federal, we do our best. We work with ONDCP and DEA, we're HHS. We try really hard, but I think what's most pertinent for you to leave here thinking about is what can you do in your community? And I like the RX STAT model that was used in New York City. We're building out a toolkit and a sort of like a module that can be used in communities so that anybody can pick it up and kind of replicate that process. As part of that process, there's a quarterly death review, so I'm glad my DEA colleague talked about the social autopsy angle on that, and that brings all your major service providers talking quarterly about what happened in this case, what could we do better, where did we drop a baton, is there a policy issue that we can improve and address? So I think that that would be a great way to work in your communities, and there are models out there, and I'd be happy to direct anybody who wants to know more about it. So thank you.
Thank you, Dr. Noonan. Well, let's give a great round of applause to our panel who did an outstanding job today. They did fabulous. I just want to thank all of you for being here today. For those that are watching live stream, we want to thank you for participating. And we're asking those that are here today to please fill out your evaluation form that's in your envelope before you leave. Somebody will be collecting it. And most importantly, thank you for starting the journey for the next 2 years in our town halls. And we look forward to seeing each of you and your communities. Thank you.